You mean getting angry reduces your lifespan? What about recreational drugs like cocaine, amphetamines, cannabis?
So cannabis is legal in many parts of the world.
Mhm.
Someone gives you a little cocaine, it's okay.
Today's conversation would be about heart health and things that are worrying the general public, conspiracy theories or rumors going on about COVID vaccines. So, for our audience, can you quickly introduce yourself and your career until now, please?
Yeah, once again, really grateful to you for this opportunity. And we realize that our jobs are not in the hospital because the real problem is really out there. So we almost think it's the same kind of iceberg which sunk the Titanic. So what we do at the hospital is just a small little bit which is jutting out. But the real problem is out there in the society. So I welcome this podcast because we want to really reach out. Because we believe that this is no longer a small problem, it's no longer a health problem, but this is an epidemic. This is an epidemic far worse than what you thought was COVID. So, in that context, I've been in this line of work for the last 20 years. I'm a cardiologist by training, and I did my undergraduation at the Christian Medical College, MBBS MD, and then I did my national boards at New Delhi. And then I went on to the US and did a year's fellowship in cardiac imaging, an area which I found very appealing since it goes hand in hand with picking up disease early and in a non-invasive fashion. And over the last 2 decades, I came back in 2008. In the last 2 decades, we've been able to put a robust infrastructure at our flagship hospital at Care Hospital, Banjara Hills, to basically detect heart disease early and to choose which kind of a patient needs what kind of treatment. Because as we know, India is a resource constrained country and you can't get pacemakers for everybody, you can't get bypass surgeries for everybody. So you need to choose who gets what. And I think in that front, we've been fairly successful. Over the last 2 decades, we've done about 20,000 odd coronary CT scans, about 6,000 odd cardiac MRIs, and about another 5,000 nuclear cardiology procedures. And more importantly, we've benefited a whole lot of cardiology students in training and at least given them the initial exposure to what preventive health is all about, preventive cardiology is all about, less glamorous than interventional cardiology, but nonetheless serving a larger section of society. So thank you once again.
Thank you, doctor. So let's start from the basics, doctor. How would you describe the heart's core architecture?
Yeah, so of all the organs, the heart is the one which is the really the mobile one. Mm-hmm. And the heart basically consists of muscular tissue. The upper part is the receiving chambers, which are, they have a thin wall. And the lower one are the pumping chambers, which obviously, as you know, has got thick muscle. So it's a beating organ, unlike the kidney, brain, liver, which is basically static. So there is a lot of things which are going on in terms of time. The time is basically between the heart contraction, which is systole, and the heart relaxation, which is diastole. And it has its own internal electrical mechanism which sort of regulates this whole thing. Surrounding this muscle is a fibrous exoskeleton with a thin layer of tissue which you call the pericardium, and it protects something like a seatbelt, sort of protects the heart from the movements that go along the thoracic cage between the lung, the bones at the back, and the sternum in the front. So the heart sits in a very, very nice sort of space, and nature has luckily given us that because the heart is crucial to the function of a human being. And as you know that when the heart stops, there is no longer life. So because of that, it has a very special little position. And because of this synchrony, the upper chamber contracts, pushing blood into the lower chamber, and then relaxes, while the lower chamber pumps and sends the blood to the rest of the organ. Now, the heart itself is divided into two big chambers. The right-sided chambers receive the deoxygenated blood, or what we call the impure blood, from the legs and from the head and neck and the upper limbs. This goes into the right ventricle, which is a thin-walled chamber, and that gets pumped into the lungs. And in the lungs, you get the oxygenation, which is between the lung alveoli, a thin sac of air in which we breathe, and there's a small little tissue in between, and then the capillary. So the oxygen diffuses across, and the carbon dioxide gets across. The carbon dioxide gets exhaled, and the oxygen goes into the blood. Now, this oxygenated blood from both lungs come into the left side of the heart, called the left atrium. And from there, it goes down a valve called the mitral valve, and goes into the left side of the heart, which is bigger, which is more thick-walled, and that gets to pump all this oxygenated blood right to our hands, to the brain, to the head and neck, down to the thorax, abdomen, and of course finally to the lower limbs. So it's a very intricate piece of architecture, and even 20 years down the line, we are in awe of this beautiful masterpiece. I call it a Van Gogh painting in motion, which I believe God has created solely for the sustenance of the human race.
What makes it beat on its own?
Yeah. So the electrical system is a whole, literally AI-driven masterpiece by itself. It starts with self-conducting tissue on the upper part of the heart, which is called the sinus node. The sinus node sits somewhere on the right upper portion of the heart, and it is a self-polarizing tissue. It's like an automated tissue, just like you have the hands of the watch in an automatic watch. And the impulses from there go down south to something called the AV node, which is something like your transmission hub. And there, with the delay of about 0.2 seconds, then the fibers go a little more below about a centimeter, and then divides into two parts, one to the left ventricle and one to the right ventricle. So this small delay allows the upper portion, we call it the atria, or the receiving chambers, to pump blood into a ventricle which is relaxed. And because of that short 0.2 delay, this relaxes, and then this pumps. And this pumps to the rest of the body. So if you had everything happening together, then the small atria will not be able to pump fluid into a much thicker and much stronger ventricle. So then you would not have that beautiful sequence which we see. So the electrical impulse has a gap of 0.2 seconds. In the 0.2 seconds, the atria relax. And after the 0.2 seconds, when the impulses reach the ventricles, then the ventricles come. So it's a beautiful symphony. And it all just happens automatically, because the cells are often automatic. It's something like an autopilot on a plane. But when disease comes in, the same sinus node which is happily beating away then starts getting disease. The other thing I just want to put into focus is we are all born with about 1 billion heartbeats. We're programmed, our bodies are programmed from birth into 1 billion heartbeats. So when those billion heartbeats get over, we die. So that's how the human race is mortal and not immortal. So we're all born with 1 billion heartbeats, and when they get over, we die. So if our heart rates are high, above 85, that's what we call the limit, we're going to consume those beats quickly. So therefore, and we'll be coming to this later in our talk, when you're stressed, when you drive too fast, when you're in an argument, and when this happens on a recurring basis, you start using up your heartbeats, just like you would use up the fuel tank if you're constantly on the accelerator pedal. And when you use them up, you start getting heart disease, strokes, so on and so forth, and you die early. The societies which have learned to train their heart rates with discipline, if you look at Switzerland, if you look at the Scandinavian countries like Denmark, the way they drive, the way they deal with situations, the way they plan for the future, their heart rates are extremely low. And that reflects on a very important parameter, the lifespan. So a Danish man average lifespan is around 90, and an Indian person's lifespan is about 63. So apart from all the other things that we've been talking about, one of the crucial things is your heart rate. And they've also found that 63% of the Indians' heart rate are higher than 80, compared to, I would say, 10% of a Danish man of the same sex, same age, same overall body surface. So in India, we have an exceptionally high heart rate, partly because of how we deal with it.
Alright. So you mean getting angry reduces your lifespan? Okay.
The classic example in the mammalian world, if I just give you two contrasting examples, is a grey whale which sits under the Arctic Ocean for most of its time. The heart beats at around 30 per minute. The average lifespan of that creature is about 150 years. The squirrel, on the other hand, which all of you are familiar with, has a heartbeat of around 180 to 200. It lives for about 2.5 to 3 years.
Interesting. So does that go with exercise as well, cardio and stuff?
Yes. So when you do exercise in a controlled environment, what happens is you're making the heart more efficient.
Okay.
So while your heart rate goes up during exercise, because of strengthening the heart muscle and also causing dilatation of the lower limb vessels, at rest, the heart rate actually gets lower. So the classic example is Usain Bolt, one of the fastest sprinters of this century, has a resting heart rate of around 43 beats per minute. But mine, for example, would be around 76. And a person who is not trained at all would have a heart rate of 95. But when Usain Bolt is on the 90th meter of his 100-meter race, the heart rate is nearing around 200. So the ability to accelerate but then subsequently decrease is a mark of a very healthy heart. By exercise, what's happening? You're training the heart muscle.
Okay.
You're training the heart muscle. So when you train the heart muscle, it's able to do all the things that we do normally at a much lower rate. It's like a good driver will have your car running in the fourth gear, even in a fairly busy traffic zone, and thereby the mileage really goes up. A poor driver or a newbie will have the car in the first or second gear, revving it up, spending a lot of fuel, not covering distance. So that's what I would call an untrained heart and athlete. So exercise makes you drive like a Formula One.
Okay.
So that's the difference.
Doctor, what's one statistic that you believe best conveys global or, let's say, South Asian urgency for heart diseases?
Yeah. So I just gave you one of the parameters, and I believe that's one of the crucial ones, which is heart rate. So how do you explain a Danish person living to 90 and an Indian living only to 63? One of the reasons, and I'm sure there are a lot of them out there, is heart rate. And I've also told you that in one of the studies that we did, it's called the Indian Hypertension Study, where we did a blood pressure of about 1,000 Indian physicians. And we found that 63% of them had a high heart rate, more than 5, compared to the European, whose heart rate was between 60 and 70.
Okay.
So one of the things that best describes this huge anomaly of lifespan, as you said, is heart rate. And how do we exhibit that heart rate? You just need to take a drive out on the road in the morning time during traffic, and you will see. So nobody follows any line. People are honking. They're impatient. They want to cross the red light when you're not supposed to. They want to take the right turn when he's right at the left. So there's a lot of urgency. But if you see a same situation, same time of day, for example, in Scandinavia, you will find that the cars are actually more. The cars are actually more. But they're all in the street. In fact, I was in a situation in Boston a couple of years ago when I did my training where there was a kind of a blizzard, an ice storm. And all the transportation was off grid, train stopped. And I happened to just take the train, so I was off the train walking. And then there's a whole amount of snow and breeze coming in, wind. And there's about a kilometer-long line of cars. And all of them are just silent. They're listening to their music, sipping their coffee. They're all just waiting in line. Nobody's in a hurry. till the snowblower comes and clears up the way. For an hour, they're just sitting and waiting. There's nobody horning, nobody. They're just sitting and waiting. So I just contrasted the scene if the same thing happened in India, and there would have been 4 rows of cars where actually there is room for only one. So when you just look at this scene, you will know why we have a higher heart rate and why we die early. I thought that's the best picture that I could actually use to describe why our lifespan is so. There are 100 of other reasons also, but this is, I would believe, really crucial.
So for now, nothing can be done about that. Are we sort of, when it comes to weather, when it comes to traffic, when it comes to, since we are densely populated, we live, in closer radius.
I'm not going to agree with that because I've been in Shanghai just recently, and the population is about 3 times the population of Hyderabad. More cars, more people. And it's just amazing to see at a traffic signal that everybody is in a straight line and everybody has a half car distance between each other. There's no honking going on. And when an old lady is crossing or yet to cross and the lights change, they're still waiting for that old lady to make that cross. So I believe population density has no bearing. It's just something that we are using to defend ourselves. I think it's a state of mind. It's a state of training, which we just discussed. Why exercise, which actually increases heart rate, is actually allowing you to live longer. So there's a lot of training, there's a lot of discipline, and all this, when you just look at it on a more global front, helps you to live long.
I want to know what's your day-to-day experience then, because since we have sort of acclimatized to the weather, we have adjusted to the traffic, and like you mentioned, getting angry, honking, we do that daily. But what's your lifestyle?
I don't. So my way of combating it is I leave early from home.
Okay.
And I'm a very patient driver. I allow people who are in a hurry to go in front of me because I know their lifespans are going to be shorter than mine. I'm pretty sure.
Okay.
At least that's what I tell myself.
Okay.
And I tell my wife also when she says, "Why are you not overtaking the auto, for example?" I said, "Nobody's going to give me a medal anyway, even if I overtake him. And besides, my fuel is going to get over fast. And I believe I want to live in a good environment where I save fuel, at least whatever I can." I'm not yet into the EV sort of scene, but I drive carefully. I drive in a higher gear. I wait at the red light, allow people who want to overtake me, and I reach my destination. I've been doing that for the last 20 years very safely without a single accident. So I do live in a chaotic world, but I've picked up a lot of the lessons that I've learned when I've been outside. And as I said, worked in sparse situations like Denmark, low population, and also experienced a high density population. And I've been able to see them and learn and try to imbibe a little bit in my lifestyle. And that has allowed me, I feel, to be a better person. It's allowed me to see my patients better. It's allowed me to appreciate the deficiencies in my patients better. It's allowed me to be less judgmental of other people. It's allowed me to work in a very hostile, sometimes combating, because cardiology is a hostile environment, it's a very competitive field. It's allowed me to grow comfortably without reaching any peak, but at the same time, I've been moving up. So I think these are important lessons that we must start imbibing when we look at societies around us, similar, and that will make us better people, and more importantly, will make us live longer, and not just living longer, but living longer and being more productive.
Makes sense. Makes sense. I know you did mention about blood pressure, but quickly for our audience, what's normal, what's abnormal, and what's a good number for resting heart?
Yeah. So blood pressure again is something that is a very continuous variable. So there's no really normal or abnormal, but various societies have more or less agreed across the Atlantic that your blood pressure should be less than 140/90. If it's anything more than 140/90, it has to be treated. Treated by lifestyle, treated by low salt, and then obviously if it doesn't work, medication, so on and so forth. 120/80 or 120/70 is considered a truly normal blood pressure. Anything less than that, there's no normal limit. You could have a 90/60 blood pressure and still be normal, provided you're not symptomatic. So very elderly people, young children will have actually a low blood pressure and not be worried about it. But as I said, blood pressure is a continuous variable. So when I see somebody with a high blood pressure, I don't start treating them immediately, unless of course their cardiovascular profile is of high risk. So for example, I'll just give a quick example where I find a young guy, he's out of college, maybe had a fight with his girlfriend, BP is 150/90, he's about 22, 23. I don't start medication. Now, similar situation, 48-year-old guy who's a smoker, he's diabetic, he has kidney disease, he's had a heart attack, maybe a stent, same blood pressure. I'm going to be very aggressive about getting it down. Starting one, maybe two, even three medications right at the word go. So I look at my patients in a very global sort of way. I call it the KYC of my patient. Like banks are so good doing your KYCs. So I do a quick KYC of my patient and I give you a good example. And I see where this person stands in terms of cardiovascular risk before aggressively treating him. So same person, same blood pressure, but different cardiovascular risk is treated very differently.
What's the difference between heart disease, a heart attack, a cardiac arrest, heart failure, and a stroke?
Yeah. So let's go the reverse. And stroke is basically a decrease in circulation of blood in the brain, although it's sometimes used interchangeably with the heart. Then cardiac arrest is a complete cessation of heartbeat, blood circulation, which if not revived immediately in the next 2 to 3 minutes will lead to chemical death. A heart attack is a situation wherein there is a critical narrowing and cessation of blood to one of the arteries of the heart. We have three arteries, one on the right and two on the left. So any cessation of blood or slowing because of some obstruction from outside or within is a heart attack. And heart disease is a very wide term used for a whole sort of layer of diseases. Could be disease of the vessel, disease of the muscle, disease of the valve. These are all the components of the heart. Disease of the outer layer of the heart, for example. So heart disease is a very wide term. But generally in the context of what we speak in society, heart disease, heart attack, sometimes is sort of taken interchangeably. But the actual truth is that heart disease is a very wide term. It comprises a large number of diseases, right from birth, congenital heart disease, to geriatric diseases. But a heart attack is very specific. It means a vascular occlusion of a blood vessel, usually because of atherosclerosis, which is the dominant player.
What are the atypical symptoms basically?
So, heart disease traditionally, and we're talking about a heart attack here, is described as a central chest pain which is constricted, very difficult to articulate. It's central. There is no defining feature, and it comes on as a squeezing kind of pain, usually aggravated by physical effort, and usually settles down when you stop or when you rest. Saying that, this classical symptom that we've been trained right from medical school is seen in only 20% of people. More true in India, where the ability to elicit a good history due to various reasons, including linguistic, dialect, language, is very limited. And 80% of people would describe the same thing anywhere between geographically the angle of the neck or the jaw right to the upper abdomen. So we have had patients going to dental surgeons, getting their teeth removed, teeth filled, when they actually had heart attack. We've had people go to gastroenterologists, endoscopy is done, normal, ECG is taken and they found he's having. So there's a wide range of symptoms starting from the angle of the neck or the jaw right up to the upper abdomen. Lower abdomen, leg, hand is very unlikely. Left hand pain is possible. But there are about 100 causes of pains when you look at pains in this area, nerve and shoulder and injury. So again, you need to do a KYC of the patient. So I get a lot of patients in my outpatient, youngish patients, who come with the typical left shoulder pain, radiating, little chest pain, youngish males, sometimes they're smokers, and sometimes they don't have an ECG as well. And we know that ECGs are positive in only 80% of the case. So if you had chest pain and you went to a hospital very quickly, your first ECG would traditionally be normal. So if you did not wait for an hour and did the second ECG for someone who had a doubt, you would miss the attack. So ECG is not a infallible kind of a test. So these people come with this kind of pain, and I just talk to them. Many of them are housewives doing a lot of housework, and typically they lift items from the upper shelves, little heavy items, and take it down. That causes a lot of shoulder pain. And when I just walk around them and I just move their shoulders a little, severe pain. I have my hands. But in the era of phone, technology, and AI, many physicians just sit, take the history, they say you have, heart disease, and they recommend an angiogram. So actually, I get those patients who refer to me for an angiogram. But when I move their shoulder, it's severe pain, and we call it a frozen shoulder. They actually come to me for an angiogram. But when I take a little detailed history, I find this lady is suffering a lot of pain. She has diabetes, she has risk factors, but this pain is not heart. So a lot of these things we miss. We do underdiagnosis. Generally, when you look at both the sexes with the same age, we miss out a lot of the symptoms in women. Traditionally, women come late. They don't exhibit their symptoms. They're so busy in their work, housework or even the office work. So we see in all the big trials, also international trials, not only India, that women's form only about a third of the big trials. And if you look at 100 people who come to the ER with chest pain, only 20 to 30 are women. So a lot of women die at home. They die on the way because their symptoms are either not appreciated by anybody, or they themselves don't come out with symptoms. Or even if they do come with symptoms, people think, oh, women don't get heart. It is completely not true. And at the age of around 50, in the perimenopausal time, women are equally prone to heart disease as men. And this is more so in India, where women have a lot of work to do. They've got the housework, children work, they go to work now. So there's a lot of emotional pressure, mental pressure, and they don't care for themselves. Blood pressure is not checked, sugar is not checked, eating is very haphazard because they keep feeding everybody. I'm just making a big statement. I'm sure there are women who really take care of themselves, but a lot of India, there's a problem. So women are underestimated and are not adequately treated for the same reason. So the mortality in women in heart disease is extremely high. So if you're a woman, if you're a lady of the same age and the risk as a man, you are going to be treated less aggressively and your outcomes are not going to be good. Especially Indian statistics, sort of global, but more pronounced in India and the lower middle income countries compared to, for example, a Norwegian lady or a Danish lady, for example, would be treated almost equally as a man.
So how do we keep women's health in check, heart health in check?
So the simple, easy answer is screening. Especially we need to focus on people who are perimenopausal. Suppose I'm a lady who has a parent or both parents having heart disease. Suppose I have multiple risk factors. I'm a diabetic, I'm hypertensive. So every risk factor adds a layer of risk. So if I'm diabetic, that's 1 point. If I'm hypertensive, that's 2. If I got a hypothyroidism, that's 3. So you need to look at these people, and if the risk factors are numerous, they need aggressive screening, and the same screening that you would do for a man. So if I do a lipid, TSH, treadmill, you need to do the same thing for them. And it has to be done periodically because you could miss in one, 6 months later you pick it up. And we are working on a technology called CT angio, where a patient goes into the gantry, typical of which you are well aware, CAT scan, 5 seconds later, you get a beautiful picture of the heart. It's a tremendous technology, and it has come about by some very interesting engineering revolutions, including what is called the brush ring technology, and the ability to produce an image when passing X-rays at a very fast rate, and also by spinning the gantry, we call it, at a very high rate, almost the rate of an aircraft engine. So this technology has allowed us to see the heart, which is a beating organ, which was never able to be seen by this technology, because we could see the liver, we could see the brain, see the kidney, but we never saw the heart. So this technology has come in about 2 decades earlier, and I've been involved with this right from the beginning. And we sort of brought this technology from the US here, allowed us to see into the heart very early. And we're doing it in a non-invasive manner. So even if a lady who's traditionally afraid of catheter going in, or the family is more afraid, she just comes, she lies down, take a deep breath, 5 seconds later you've got a beautiful picture of the heart, which the treadmill, echo, and all the other screening techniques have actually missed. Because one of the important things we want to tell the audience is that 70% of the heart attacks happen in arteries where the lesion is less than 30%. So I'll just rephrase this. Most of the heart attacks are caused by lesions which don't approach 70%. The ones which have got tight stenosis, which we look at and get afraid, they actually don't cause heart attack. They cause angina, they cause chest pain, they cause exertion symptoms, they don't cause heart attack. Heart attacks are caused by lesions which are very small. Because you get a heart attack not because of the lesion closing, but because of rupture of an existing lesion, liberation of all those thrombogenic products, and then the artery is closed. So that has been a revolutionized sort of pathogenesis that we understood about 2 decades ago. And this is the only technology that we know right now which is non-invasive that can see those small plaques. Treadmill, for example, will pick up these lesions when they're more than 70%. Do-between stress echo has the same thing, 70%. Nuclear techniques like stress maybe, for example, which are very widely done in the US, Canada, and we are also doing, picks up the lesions only when they are 70%. By that time, it's too late. So CT angio is the only tool that can pick up the lesions very early. And now we have wonderful drugs that we're going to be talking about, which can arrest the progression, prevent progression, and in some cases even reverse.
Okay, let's come back to symptoms again. You've explained about women, but about men, you mentioned that pain from jaw to your abdomen. I mean, how can a lay person, or how do I understand that this is something unusual? Because when I lift in the gym, or I basically get pain over here in my wrists, and sometimes we are clenching, so in jaws as well. Also, because of acid reflux, we do have chest pain. But how do we know that no, this is something unusual?
Yeah, good question, but I'm afraid the answer is a little too complex, and that's the reason why we miss a lot of heart attacks. We miss a lot of heart attacks. Despite today's age and term where we have so many, where everybody's tuned to a heart attack, we still miss it. Because it's very complex. It requires a very astute physician to look at a person, do the KYC, and tell you whether this is actually cervical, or in a pre-existing cervical, is this something new, just based on the story the patient is telling and his ability to discern the facts from whatever fiction is going on. And because of this, we have been missing a lot of heart attacks. And it's not India, it's the world over. So we have, because of this problem, we have devised a huge layer of investigations, including an ECG, a second ECG. We have a blood test called a troponin T, troponin I, very sensitive, which picks up a small amount of injured muscle in the blood before it really causes an occlusion. And then the echocardiogram, which looks at the heart pumping and any change. And most importantly, I talked about the CT, where we're able to see a blockage, even very mild, very early. And despite all this, I would say our ability to diagnose a heart attack, even in a good center, and I'm just giving a big number, is around 80 to 82%. 18% would still leave the ER with an undiagnosed heart attack and go and die or collapse somewhere else. And the converse is true. The converse is true. And that would be more in the Western countries, where patient comes with a cervical pain and you've done a huge layer of investigations. Finally, not sure about what's happening, admit this patient, a lot of taxpayers' money goes away, insurance money goes away, and you discharge them the next day without being sure what happened. So all these permutations and combinations are possible because it's a very complex thing. And I won't be doing justice by telling you how we as experienced physicians are able to fish out those key discerning points which allow us to tell you whether your existing cervical spondylosis is not the same, but that added layer of pain that you have been happening for the last 3 days, especially exacerbated by movement, by activity, is a new heart disease on a pre-existing cervix. But to pick that up requires a lot of experience, literally. And as cardiologists, we are, I would say, well in the experience game. But even we are fooled at multiple times. So the bottom line, as I always say, is that when you have these kind of odd symptoms, that means you've been having cervical pain for the last couple of years, and suddenly the pain is there, but it's much sharper, it's much more in duration, and doesn't settle down with the conventional medicines that you use. So that's a red flag, and you need to seek medical attention urgently. So the good thing that has been happening over time, and partly because of how you've been taking these issues into mainstream, is that I get at least about 10 to 15% of my patients in my outpatient are pretty young people with no risk factors having pain coming to a cardiologist. He actually has a cervical problem. He has a shoulder, should be going to the orthopedic. But he's really worried because of mainstream media. And he comes and says, "Doctor, I have this. I think it's," and I moved and say, "Hey, you've got shoulder." He said, "But doctor, just still rule it out." So it's made my life a little more busy. But I smile and look back and say that at least the message has been catched. That, everybody's worried about their heart, and they know that if they miss it, they're going to get into heart failure, and they're not going to be able to do their activities properly. But if you miss a cervical problem, it doesn't matter. You just get treated by the next physician. So the awareness is moving up, at least in the metros, but I'm sure there's a long way to go before we pick this up. But it's a very complex issue.
Okay, so with these things in place, how does a common man from non-medical background keep his heart in check?
Yeah, as I said before, screening. And you've got all these nice online screening things which are available at a very good cost. Some of them are not very accurate, but still, I think a routine 6-monthly screening and showing these reports to a trained or a registered medical practitioner, preferably someone who has an experience of looking at patients with heart disease, does not need to be a cardiologist. Could be a physician, could be a trade physician or even MBBS doctor, but you should have the experience. So I think there is no substitute for regular systematic screening. And we've been lucky that a lot of these things are online, they're pretty cheap. You've got a whole plethora of tests available at a click of a button. And I think that's the only thing that is going to help us pick up these things early and get treated.
Okay. So before we move to our next segment, I just want to quickly prime our audience about what cholesterol is, HDL, LDL, and all the jargons basically. Since heart issues are multifactorial, to my research, in my opinion, I don't think cholesterol should be the only factor to judge one's heart health. So, can you quickly explain what is cholesterol, how much of it is present in our body, and what's LDL, HDL?
Yeah, just trying to make a very complex subject simple. I'm going to just draw you to a sort of illusion where the three main constituents of cholesterol. Cholesterol is nothing but fat. 30% is ingested, 70% is actually produced within the body, endogenous. Cholesterol has three big components. One is the LDL. The LDL, I'm going to make you think about it as a garbage. HDL I'm going to think of them as garbage trucks. And triglyceride is the guys who are driving the garbage trucks.
Okay.
So what happens is, because of various reasons, including ingestion of unwanted fats, ghee, dalda, processed food, so on and so forth, junk food, the garbage keeps increasing. Is normal in a city. And the HDL are the garbage trucks that come along, and they are paid by your taxes. So they have a role to come and they pick up the garbage. And the triglycerides are, it's not garbage, but it's a very badly trained garbage truck driver who doesn't allow the garbage truck to come on time, doesn't drive it properly, doesn't pick up all the garbage. So all these three things together are what we call the cholesterol family. And if you have too much of, for example, garbage, and the right amount of the garbage trucks, you're still going to get in trouble. If you have slightly more garbage, but the garbage trucks are too few, you're again going to get in trouble. And if you have a high amount of triglycerides, the garbage truck is not going to be able to see the garbage and not going to pick it up efficiently. So the interplay between all these three, I've just made it very simple, is what causes heart disease. Now the garbage goes and gets stuck onto the roads, and you know what happens when the garbage guys go on strike? A 3-lane, 4-lane road becomes a single. That's exactly what happens in the heart vessels. So when the garbage becomes more, an artery which should take 3 meters per second flow easily becomes constricted. And the garbage is not just a physical garbage, it's a garbage which can become very inflammatory. That means a garbage could also have, for example, kerosene, could have, incidental products in it, that if not treated well by the garbage truck can actually explode. So that's what LDL has. And when it explodes in the confines of a narrow artery or a road, you have a heart attack. Just like what you would have as a traffic jam. So if you're able to look at the picture that I've painted, you will see that the lower the garbage, the higher the garbage trucks, and the less of bad garbage truck drivers is going to lead you with excellent roads, good drivability, and no traffic jams. You're going to reach your destination fast, quick, at the least amount of time and expense. So exactly that's what happens.
Okay.
So if I have less garbage, my garbage truck drivers are doing a great job, I'll be able to do a full day's work without getting anything. But if my garbage is more, I will still be able to get through the day, I'll still be able to do my work, but it will be at a huge pace, just like what happens in the high-tech city traffic at around 10:30 in the morning. I happen to be stuck in it. It's terrible. So that's what happens in the heart.
Okay. So you mentioned ghee, in every household of India, few people say it's cardioprotective, doctors say it's cardiotoxic. I want to know if it's context dependent or it's actually cardiotoxic.
Yeah, ghee essentially is saturated fat.
Mm-hmm.
So whichever definition you use, saturated fat is something that feeds LDL cholesterol. So by any measure, context, not context, whether your grandmother said it or your great-grandmother said it, ghee is dangerous. Now, at a time 40, 50 years ago when there was a severe carbohydrate deprivation and a lot of our ancestors were literally starving when the British left us penniless, ghee was a very important thing because ghee is fat and fat can be converted by the body into fuel. It allowed the country to work in factories, work in the field, work in the school, work in building construction, and allow modern India to develop when there was none. But the same ghee today, when you have all the buildings and the cars and the roads and the planes, is not going to be able to be converted to energy because there's already energy surplus. And where does the ghee go? Right into the artery.
I'll give
So
you.
what was good for our great grandmothers, for example, is not good for you.
Okay. I'll give you a fitness trainer's version on this. So, few people who follow ketogenic diet, they believe that 1 gram of carbs has like 4 or 5 calories, and it goes into your body and spikes up the insulin and glycogen and all that jazz. Whereas fat, 1 gram of fat has 9 calories, doesn't spike your insulin, doesn't get into glycogen and all that. Once entered in a ketosis state, can be an efficient fuel for metabolism and for having a healthy heart rate. Is that true?
Partly, partly. While ketogenic fat is something that we also sometimes advocate for people who are extremely obese, but these cannot be done indifferently. As you know, humans are a product of God's creation. And the whole buzzword about creation is everything is good in the right measure. So you can't sit and say that I live on a mountain and therefore I am better than you who's sitting on a seaside. Or a mountain is more beautiful than sea. You need to have a mountain, you need to have a valley, you need to have sea. So the body requires all the three. Requires fat, requires protein, carbohydrate, just the right measure. Now, your measure is different. You may be doing weight training on a regular basis. You require maybe more fat, more protein. I may not do weight training. I may be doing more of aerobics, so I need more carbs. In different works, for example. The beauty is in the balance of it. So we don't villainize any one thing because all three are important. They all go into the building block of a human tissue. So by saying that you take only fat, ketogenic is good, that's not true. It's the delicate interplay between all three which really makes good health. So rice is good, fish is good, salads are good, but it has to be in the right proportions. And that's where we're going wrong. So sticking to a specific diet for a long time is dangerous. Because the body has been designed to accept carbohydrates. Body is designed to take protein, designed to take fat. But the proportions which you have to be careful about. So I find some of these diets are actually deleterious in the long run. In the short term, you're doing muscle training, you're recovering from a heart attack. Some of these ketogenic diets are good, but they're not something that I would adopt on a whole scale. For the simple reason, as I said again, we are a product of God's creation, and every little bit which is available to us is actually good. It's the proportions that matter.
Okay. Can you describe an ideal heart healthy plate?
Yeah. So I'll just contrast.
Sorry, one more thing. And where are Indians going wrong?
Yeah. So just to put that again, I just painted a little picture of a Danish diet, and I'm only saying that because they have a very high life expectancy. I'm not saying they're right or wrong. And I'm giving an Indian plate, we live to 63. Now, at the centerpiece of this Danish person's diet is protein. Could be vegetable protein, could be non-vegetarian protein, could be lean meat, whatever. Surrounding that, there is a lot of salad. There's a yogurt. There is a little bit of rice or maybe a brown bread. And adjacent to that is a cup of soup. Soup. And a small glass of red wine. Now, let's get back home. And our plate has a large amount of rice in the center, small bit of chicken, little bit of paneer, curd is there, hardly any salad, and no red wine. Now, what's the thing which is going wrong? Both are plates, both have calories, both have protein, both have carbs. Now, our diets are very rich and loaded with carbs. So 50% of the plate is rice. The Danish guy's plate has rice, is 10%, it's 15%. His protein is about 40%, our protein is 20%. Fat is less than 10%. It's about 15%. But what is really adding value is the yogurt, the salads, and the glass of red wine. So we call that a traditional Mediterranean diet where there's a very beautiful interplay between the protein, carbs, and the fat in the right proportions. And all of them are in a 20 to 30% sort of ratio compared to here where 60% of the diet is white rice. And we know that white rice is highly energetic. It goes in and does the same things that you've just been talking about. Spike in energy levels, a spike down in energy levels. And that's the reason why I find a lot of people are so irritable. They're so edgy, they're on the nerve. Because all the rice which they ate, if you see the traffic at 4 o'clock, you'll know what I'm talking about. The rice is gone at 1:32. They reached a spike by 3. By 5, all the and it's going down rapidly. Blood sugar is going down. So this guy is in a hurry. All his systems, it's like how the caveman responded to a saber-toothed tiger. He's all on edge. He's got a small club. He's got a big tiger in front of him. And he wants to run. And if you see what happens at 5 o'clock here, it's exact. People are racing. And I feel they're racing to get that next meal because all the carbs are burned. Contrast this with the European driver, and you'll see at 5 o'clock they have more cars than us, believe me. And the roads are not that big yet. And you'll see them going in straight. Because his protein meal is still not worn off. He has good energy in his blood. And because he's a conditioned runner or he's a conditioned exercise person, his muscles are relaxed, heart rate is down. He knows for sure that he's going to get a nice little meal at home because he's got a good family. He's given his wife a lot of importance. And there is going to be good sharing at the dinner table. Here, you've already, messed around with your wife in the morning, and women are not adequately represented in our Indian context. Most part, I'm sure there are examples. So, whether the wife is going to serve you that hot cup of tea, or decline it, or not make it, run away to her mother's house, we don't know. And that explains a lot of the edginess that you're seeing in these guys. In fact, one of my British colleagues who was with me for a few months found that none of the guys come on time to the hospital in the morning. Then we did a party once a month or once in 2 months. You would find that nobody's reaching the party also on time. And then when the wives come in for the party, they keep asking him, saying, "Why do you keep our husbands so late?" He said, "These guys don't come on time. They're not reaching their homes on time. So sorry for using this expletive. Where are these bloody Indians going?" If they're not coming on time, they're not reaching their home on time, where are these guys? They're all on edge. And that explains that the sympathetic nervous system is highly developed in Indians. Our heart rates are high, partly fueled by this huge carbohydrate intake we keep taking. And because of the high sympathetic rate, we're using up all our heart rates. And what happens? We die early. What do we die of? Cancer. Because of saturated fat intake. We die of heart disease. 35% of Indians die of heart disease. We die of strokes. So if someone says, "Why are Indians dying?" I say there's no mystery as far as I'm concerned. The way we eat, the way we act, the way we deal with each other, you can see what happens when politicians go head to head in most places in the parliament, how we behave. So is it a surprise that our mortality rate is so high? Is it a surprise that our heart disease is so early? I don't see any surprise at all. It's not that we come from another planet. It's just that our behavior and our training has been so bad.
Let's come to meat and eggs. There's a different version what vegans give, and there's different version what non-vegetarian carnivores give. However, have you seen a movie called Game Changers? It's on Netflix. So that study is not basically approved by FDA. It's not validated and stuff. However, the doctor does measure fat formation in the arteries once an athlete eats non-veg, and what's the result after he eats peas, beans and stuff. So what I saw in that video, in that movie, was people who ate non-veg, their blood was cloudy, and when they used it in a centrifuge, there was an immense amount of fat coming out in plasma. But when it comes to beans and stuff like avocado and stuff, I couldn't see any fat formation. Can you explain about that, please?
So just to put things in context, if you look at early human, which is about 6,000 years ago, early humans survived on the animals he killed.
Mm-hmm. Like a paleo diet or something. Yeah.
So early human, the only source of nutrition was to kill an animal and eat.
Yeah.
He's non-vegetarian.
Yeah.
It took him almost 2,000 years to have a grain-based, agri-based diet, because he wasn't planting anything for almost 2,000 years. So if you just look at that little history that I told you, man is just designed by God to be a carnivore. There are no two things about it. So whatever else you add on, vegan, milk vegan, egg vegan, is all artificial.
Okay.
Now, one of the very important things I will again try to portray. Now, there is a substance called B12. And B12 is one of the most critical vitamins that we know of, along with vitamin D. Very important for the conduction of impulses along the nervous system and the brain regeneration. So B12 is a very, very important tool. It also helps in forming the red blood cells and helps you to carry iron and oxygen across the body. Now, non-vegetarian food has B12. Vegetarian food also has B12. Both have B12. Cows, oxen, sheep, they all take their B12. B12 is necessary for mammalian life. So they have their grassy diet and they get the B12. We have non-veg, we get the B12. Now what happens when you eat veg? Vegetarian food has B12. But the human system does not have the enzyme to cleave B12 out of the veg. So what does that tell you? That one of the very important food components that we are going to eat is non-vegetarian. Simply because if I talk about B12 being one of the important auxiliaries of life, important component of life to carry my blood, to use my brain, I use B12. And the fact that I don't have an enzyme to cleave it out of a vegetarian-based diet, it really tells me, and I'm just talking about prehistory, historical man, that I'm designed to be a meat eater. I'm just putting this out there so that you don't feel that I'm a pro-carnivore or pro-omnivore. Saying that, as I told you about your debate about protein, carbs and fat, it's all in the proportion. So if I'm going to eat meat morning, lunch and dinner, and I'm going to be eating red meat breakfast, lunch, dinner, certainly what you saw in the movie is true. My blood is going to be very turbid, my fats are going to be going up, I'm going to die of colon cancer, stomach cancer, I'm going to have all these. But what if I didn't eat it breakfast, lunch and dinner, but had the same thing once a week? Because B12 is such a fine substance that just a few micrograms are enough for you for a week. And what if I were to tell you that instead of having vegetarian food every day, I did it 4 days a week? And that's when you see the true beauty of nature. It's all about the proportions. So I'm not saying protein is good, I'm not saying non-vegetarian is good. I said God has designed us to partake of everything, but in the right quantities. And what is the right quantity? That's the KYC for you to figure out. If you're an athlete, you're into bodybuilding, or you want to represent the country in a weightlifting competition, you certainly got to have your fats. You got to have a lot of ketogenic diet. You got to have a huge amount of protein. You got to be having huge amount of red meat. I know some of my patients have about 12 eggs a day. Certainly, why not? Because you're pumping that kind of iron. If you're going to do cross country or marathon, certainly. But what if you're a guy like 80% of us who go sit in the morning, we sit in the evening, sit in the lunchtime, and we even sit at night staring into our screens? You need 12 eggs? Is 1 kilo of beef good or bad? Or is 2 liters of milk good? Certainly not. So when we talk about these things, we need to see for whom. When we say we want a complete EV in the country and we want to copy Norway, which has 90% EV, really? EV in this country when half of us use kerosene?
Exactly.
So what are we talking? So I don't believe we should be getting into such specifics and such debates, because human beings are built in diversity. We're designed to eat a little meat, we're designed to eat a little bit of veggie, we're designed to eat a little bit of plant, we're designed to eat a little bit of carbs. So that's the beauty of a human. We're not tigers and lions that we should just attack a deer and eat. We're a higher form of creature that God has designed. So when we look at who we are, we also need to know what we should have. So any extreme, ketogenic extreme, pure carbs, pure vegan, milk vegan, I think just an artificial overlay that we have put onto ourselves and just added a whole layer of stress which is not required.
Not required. So what if someone is an athlete and has different, let's say, muscle building goal? Usually fitness trainers, when in the muscle building phase, they suggest double the body weight. Is that healthy or not?
As long as it's done with a goal, as long as it's done by a trained physiotherapist or a trained a trainer who's certified by some body, certainly yes.
Okay.
It's like saying my driver drives in fourth gear and drives at about 80 in the city. Why not? The trained driver has got a good vehicle, he's been driving for the last 20 years and he's never had an accident. Why not? Fourth gear, 80. Sounds incredible, can be done. But if I'm just learning how to drive and you say that why don't you drive at 80, fourth gear, I'm going to be killing a lot of people. Yeah. So who is the person and who is the person teaching him makes all the difference.
Okay. So what do you think is a real cardiovascular danger when an athlete is consuming a high protein diet?
That's what I said. If he has a clear goal, if he's got a good trainer who's well schooled with diets, well schooled with weight training, I don't see any danger at all.
Okay.
The danger happens when the trainer is not good, he's not well schooled, and if the athlete is not doing athletics but has stopped and still continuing that old.
Okay.
So that's the danger.
Okay. So let's say if someone wants to have body fat percentage less than 10 or 9, would you call that healthy?
Certainly not.
Why is
Certainly not. Especially if it is not done in the right way, it's not done without proper supervision. You could get into something called sarcopenia. Where, along with the weight loss or along with the fat loss, you're depleting your body of protein as well. It is dangerous.
Okay.
So sarcopenia is something that has been, we're seeing it, where people deprive their body's ability to eat, going on very stringent diets, pure fat, pure protein, no carbs, and they start losing protein. They start losing muscle mass, they start losing the luster of their skin. Humans, we are beautiful people, we're not designed to look like robots.
Yeah.
We must have a certain roundness, we need to have a certain curvature. So when you go for these extreme things, and most of these extreme things are driven by people with neither much scholarly sort of interest and more of a commercial interest when it comes down to it, that's the danger.
Okay. Let's come back to LDL again. What one change in a typical Indian plate would reduce LDL dramatically. Protein?
The proportion of carbohydrate.
Okay. So
We said that carbohydrate is 60%. You make it just under 50, maybe 40. I think you've done our job. So the proportion and the size of the plate. So instead of having a large plate, I go with a small plate. The rice, which was 60% in the large plate, becomes 40% in a small plate. That means the proportion is getting smaller, the volume is getting less. And that's enough.
Between smoking, hypertension, high LDL, diabetes, and stress, out of these, which causes most heart-related deaths in India and as well as globally?
Yeah, so they've done a large multi-center trial where they've looked at the relative proportions of a specific risk factor. It's not obviously going to be ideal because they never compared it head to head. But what they did find was interesting, in fact, very interesting to me. So they looked at smoking, diabetes, hypertension, father's heart disease, family history. They were all around between 2 and 4% in terms of getting heart disease. And when they looked at LDL, it was 9 times.
Okay.
Which is amazing for me. That even smoking, although is not a good thing to do and does cause heart disease, the propensity to cause heart disease is only 3 to 4. And it's the same for diabetes, hypertension, give and take a little bit here and there. Obesity as well. But when you looked at LDL, it's 9 times. So that tells you the huge risk of LDL, and the big danger of LDL is silent. When you see someone smoke, you immediately want to correct him, you want to change it. You see someone is fat, you want to get him on a diet. You see someone's high sugar, you want to control it. You see someone's blood pressure going high and having headache, you want to take it. But who sees LDL? So the biggest danger is what is under the iceberg. So that's the reason why I keep saying that the only secret of living long is to do these master health checkups on a regular basis and to be seen by a trained physician with specific eyes for preventing heart disease or cardiovascular disease, because the big danger is under the surface. That's it.
Okay. What about recreational drugs like cocaine, amphetamines, cannabis?
So cannabis is legal in many parts of the world. Netherlands, Belgium. I'm not going to go into the social issues. Suffice to say that anything which disturbs the nervous system in any way is not good. But when you look at the propensity for it to cause heart disease, like I just mentioned, it comes on a scale of about 3, 3.5. The LDL is 9.
Okay.
So I'm not saying take cannabis, not take cannabis. They are certainly dangerous things. And unfortunately, they're taken by young people. And that is cascading the effect of heart disease in young people. Certainly not. But I would say the problem of this is very minuscule compared to what LDL is there in the community. Because when you see someone taking drugs, generally in a civil society, you would make those measures. He has a higher chance of having, vomiting and blurry vision, and then he comes to the hospital, then you take care. And he needs psychiatric evaluation, all that stuff, de-addiction. But to me, the true problem is something that you don't see. Like we described, like you talk about air pollution, like you talk about bad driving. So these are things which, as you said rightly, almost seem normal. So for you, if you find people crossing lanes, horning, tailgating, as an average Indian, you say this is normal. But the danger isn't that normal. So that's what I'm worried. So when someone tells me their LDL is just 140, so what, sir? The range is there. If you look at a blood report, 130, 140 is slightly elevated. So having drugs is bad. Smoking, bad. But the propensity to cause heart disease is so low.
People doing cocaine, methamphetamines, and if they are overdosed, they do get hospitalized. I'm not a doctor, so I don't know what happens behind the curtains. Can you explain that?
Yeah, as I said, if you're a first-time meth user, cocaine user, certainly when you do a little bit of overdose, you have a high heart rate, blood pressure goes up, you have some visual issues, some brain changes as well. And don't be mistaken, they do get heart attacks as well, because cocaine is basically a vasoconstrictor. Perfectly normal artery gets constricted. But please remember that these kids are essentially normal. They hardly have any plaques in them. So if you survive that episode and you don't take too much of it, of course, you take too much, you get OD'd and you die. It's no doubt. But most of them really don't take that much. Just recreational players, just wanting to have a little fun, snort a little cocaine, and they're otherwise normal. So when you do that on a normal person, the net effect is not bad compared to if the same cocaine is taken by a 60-year-old who already has plaques. So that's the reason why drug abuse is still tolerable, because it has not caused so many deaths that would have changed society's outlook. So for example, you look at the recent air crash, the worst in aviation history. I think 241 people died. But did you see any change in air bookings and everybody going and catching a train?
Absolutely not.
So that's the same thing with drugs. 90% of the illicit drug users would just get away with a small hospital admission, pump his stomach or get an IV and walk off. So because it is so commonplace, it has not allowed society to really change their behavior. So if you go to a particular nightclub in UK or some parts of India as well, Mumbai, someone gives a little cocaine, it's okay. Because it has not caused that many deaths that would have changed the social behavior. But when you're talking about LDL and you're looking at the number of deaths, and I told you that India has possibly the highest mortality on the planet in terms of cardiovascular disease, that's what I call something that needs to be done. And affecting a large, wide variety of people. Housewife, businessman, politician, college-going guy. Whereas if you look at the drug users, I'm just giving broad numbers, they're minuscule compared to the overall society, especially in a country like ours where it's still taboo to take drugs. And if you just ask me the number of drug users in a community in India, I would say it's about 0.3%.
Yeah.
But if you look at heart disease because of LDL, very wide-based. And so certainly demands a lot of attention.
Since the numbers are too low, have you ever seen people who are getting hospitalized, or have you treated someone?
Yeah. We have of course I can't use a name, but we have a pub just next to our hospital. And every Saturday when I was on duty, I used to see these people come in and go. And I said 9 out of 10, they just walked away. They didn't even get admitted.
Okay.
Stomach wash, some IV, 3 hours, admission, and go. I did see a couple of deaths, very small.
Okay. Coming back to smoking, how soon does body start healing? And how soon does cardiovascular health start healing? Right after you quit. And how is it different in different ages? 30, 40, 50?
So it takes about 5 years to get the smoke out of your system. Completely. So if I stop smoking today, I'm going to get to your lung. You're a non-smoker. It takes me 5 years. But in the first 3 months itself, what happens is the nicotine level goes down. And your propensity to develop a heart attack
comes down. Okay. So we hear a lot of our, including my father as well, my father and his friends, like, thoda daru sahi hai. So is it true, or it's just their silly justification to have a drink?
So alcohol chemically is a metabolic poison. Alcohol by its own nature, just being alcohol, whether you say 3%, 5% beer, 8% wine, 28% whiskey, some people have even 32% brandy. So alcohol by its very nature is a metabolic poison and it kills cell. It is a cell killer. It causes cell death. So if you look at that by its property, certainly not a good thing.
Okay.
But then, as we talked about illicit drug use, and if you look at the wide range of alcohol users, which I would, again, I'm just putting out a number. Telangana is one of the highest consumers of alcohol, by the way. I think we've just pipped Punjab, or we're just behind Punjab. And I'm just putting a number out there saying 10% of people in Telangana have alcohol. I'm sure it's more. And if we look at the people who are dying of alcohol, it would be about 0.1%. So that habit is obviously not killing enough people to cause a major shift.
Okay.
So when COVID hit, because it hit big way, and many people died, it became something very alarming. Because you see a person getting COVID, and 3 out of 10 people died. Although it was in a very short period of time, maybe a year. Alcohol is over, I think, the last century, if I'm not mistaken, maybe more. Molasses was discovered and then alcohol happened. So if you look at the number of people who died because of alcohol, the numbers are there, they are small, and they're being spread out over a large amount of time, which makes it, like drugs, an acceptable habit.
Okay.
So if you just drank under the radar, less number of times, once in a while, you would just get away with a little bit of liver enzyme going up, a little bit of abdominal discomfort, maybe 1 or 2 episodes of gastritis, and you're okay. So it is not allowed us to change our behavior radically.
Okay. How about 2 pegs a day?
Yeah, that's what I'm saying. So again, the 2 pegs would depend on who you are.
Okay.
So if I'm a young kid, 17 years old, out of college, 2 pegs of single malt can cause disastrous effects on me. Because I'm a first-time user and I'll be zonked out. I may have to my stomach flush, I may have to my liver enzyme. But what if I'm having alcohol for the last 40 years, like our parents did, our grandparents did? I developed something called, I just get conditioned. So my body starts developing a kind of a tolerance to alcohol. So the 2 pegs that you gave to that kid and he was like throwing up in the washroom, I will need 8 pegs to have the same. So body develops a little bit of tolerance. So because of that tolerance, I get very confident. And I've been drinking alcohol for the last 40 years.
So a patient who's going to get operated for enlarged prostate, safe or not safe? Alcohol.
Certainly not on the day or the day before surgery. Certainly not. Neither safe to smoke, neither to have alcohol. Certainly not. But again, as we've just talked about, fatalities which will influence what you're doing. If I had a small peg of alcohol, I'm not saying it's good. My mortality post-operative wouldn't change by too much.
Okay.
I would have a little deeper anesthesia. I would get out of anesthesia a little late. Maybe have a small infection in the lung. But I would get up. I'm just trying to put into perspective why I've seen people even having a smoke before surgery. Because involuntarily they've looked at large data themselves from wherever it came from. May not be conditioned data, may not be good quality data. And they found that all their friends who also had a little smoke pre-operatively all did well. But that doesn't mean that's right.
That's right.
And the issues that happens peri-operative, post-operative make a difference in your recovery time.
Okay. What habits in teenage of a person could reflect in as a cardiac risk in their 30s or 40s or 50s?
Certainly, suppose I was a teenager, means smoking, consuming alcohol, or having illicit drugs. As I said, these are all metabolic poisons. And over time, over many years, my ability to cope with a sudden infection. So, for example, let us say I have alcohol, smoking, and I also use drugs, and you are completely clean. 10 years later, both of us get COVID. Guess who's going to survive?
Makes sense. Let's come to the next segment, stress, sleep, and hypertension. How exactly, I want you to explain the biology of stress raising blood pressure or cardiac workload.
Yeah. So we've already discussed this to some extent about how I find that heart rate is so central to our existence on this planet. And I've also, I don't know whether I gave you this example of a grey whale under the Arctic.
Yes,
I
you
said
did.
that, yeah. So that's why I find it a very central theme of our whole existence. So now, when you deprive yourself of sleep, when you get into a rage, when you are at a kind of, a kind of an agitation, all these things together cause only one thing in the pure biological sense. It shoots up your heart rate because they all activate a system called the sympathetic nervous system, which is a chain of nerves or neurons right from the upper part of my neck going right down to my thorax. And that's what we call the gas pedal of the car. Now, just next to it, scattered, not that organized, is the brake pedal of the car, which we call the parasympathetic system. Now, the interplay between both is what is important. That's what I've been talking about, the whole theme. Not veg, not non-veg, but a little bit of both. Not carbs, not protein. So, in China, they call it the yin and the yang. So, in a tough situation, I see a saber-toothed tiger. If I'm not able to muster up my sympathetic nervous system to get my body into a flight or fright response, and my muscles get tense, and I'm able to propel my body fast out of that situation, maybe go into a heart rate of 180, I'm not going to live. If I'm going to stand there, do a little meditative pose, stand on one leg and do a yoga, guess what's going to happen to me? I'll be eaten up. So, the interplay between the parasympathetic and the sympathetic system is what makes us live long and also live productive. So we need sympathetic system certainly, but we also need the parasympathetic system. And the sympathetic system is on the job, on the run, all the time. That's the danger. It's like eating bacon 3 times a day. Bacon is good if you had it once a week. It's good for the muscles, it's good for energy, it's good for anaerobic energy. But if you're going to eat the same bacon 3 times, guess what's going to happen? You're going to die of a heart. So, when you blow up once a week, it's something that was done completely wrong. Certainly, there's a normal human being. Nobody wants you to be a robot. But when you're blowing up all the time and you're always on the edge and you're not sleeping at all. Now, today I'm going to go home and I'm not going to sleep much. Thanks to you. But if I did this day after day after day, so I do angioplasties at night for patients who come with an emergency. So my sleep gets disturbed. I do it once a week, twice a week. But if I'm going to do it day after day, like if I'm in the army, if I were a pilot of a international flight, for example, that's dangerous. Because you're not allowing the yang to get into play, the parasympathetic. You're not allowing the brake to start. So if I were to tell you that I'm going to give you a car with either an accelerator or a brake, which you're going to choose? Stop. You need the brake, but you also need an accelerator. You're going to have stuff. So the whole interplay between these two systems makes us what we are. Too much of parasympathetic, we're like robots, like AI creatures. We have predictable responses. We don't have emotions, just like AI. And we're just conditioned to do things as someone is programmed. But on the other hand, if we get too emotional and too much of sympathetic, less of sympathetic, then you're pressurizing the sympathetic system. The heart rate is always high, and that's a deleterious effect on the rest of the body.
Okay. So, what's the ideal duration of sleep? and what happens if you get less than that, and how does chronic sleep debt reflect on your long-term heart scans or reports?
So there is no real duration of sleep that is ideal.
Mm-hmm.
But what we have learned is that the body is like a factory. And between 11 p.m. to 4 a.m. is when all the factory doors open and they're ready to do business.
Mm-hmm.
Now, what are those factories? Salt factory, that's hypertension. Cholesterol factory, the fat factory, that's cholesterol. The sugar factory, that's diabetes. All of them open their garage doors at 11 and they close at 4. To open completely, you need to be in deep sleep. No dream sleep, no sitting on the YouTube, no driving, no text. You need to be in deep non-REM sleep. That's a kind of sleep. It's the deepest sleep. That's when the factory doors completely open all the way out and all the processing happens 100%. So you could be on a bad diet, but if you're getting good sleep, technically, you'll be able to digest all. Now, the same 6 or 7 hours that we spoke about cannot be replicated any other chronological time of the day. So you can't say that I'm working 11 to 4, but I'm going to sleep 6 to 11. The body is just designed because of our centuries or millennia of conditioning that when the sun went away, you rested. Armies in the past didn't fight wars at sunset. They took care of their injured, they drew ceasefire lines. Today, that's all gone. If you see the recent warfare that happened across our border, we struck them at about, I think the time was 2 a.m. And they were actually trying to attack us at 4, but we struck at 2. So we have redrawn what was historically good practice of fighting a war. And the Americans do it all the time. They attack at 3 or 2:30 at night. And they're now building up a whole team of soldiers who are trained to work at night exclusively. Because most of the other armies rest at night. So looking at that and pausing a little bit, any interruption of sleep in the 11 to 4 a.m. period, and when it's replicated day after day, week after week, month after month, is going to come with deleterious effects. And the deleterious effects are going to be more salt, more sugar, more fat, and all these three together, they call heart attacks. So if you were to tell me that why are the young people who are awake at night, they're in BPOs, call centers, American job, and why are they getting heart disease? Well, I'll say that's not, it's a no-brainer. Because one of the most important components of human life is to recharge at night. The body needs to recharge because the body is working continuously. We are as good or better than our phones. And you know what happens when you get stuck in an airport, flight is delayed, and there's no charger. That's it. Gone. And no amount of tapping and kerosene is going to get that phone back. So the phone needs to be charged. What about us? Certainly. So if you're not going to charge our bodies, one day you escape, 1 week you can escape, 10 days you can escape, 2 weeks. But after that, it affects it.
Makes sense. So on that, when it comes to workplace and stuff, is burnout or financial anxiety, is that underestimated?
Yes. So as I said, again, I'm going to just repeat myself in saying that heart rate is everything. So when I lose money in the stock market, what happens? My heart rate goes. I lose a partner in a relationship, my heart rate goes. I'm not sleeping well. I'm on the edge. I'm drinking too many cups of caffeine. I'm having too much of carbohydrate. I'm doing too much of excessive work in the gym.
Mm-hmm.
What is a common thread?
Heart rate.
And then if you tell me, why did someone have a heart attack after losing his girlfriend? No brain. Why did someone die 1 week after his spouse died? No brain. So I believe one of the most interconnected things is we generally don't look at it because we don't measure it. When I ask my patients to check their blood pressure, they conveniently look at systolic, diastolic, they don't mention it.
Mm-hmm.
When I look at prescriptions from other doctors, community physicians, family care physicians, there's a systole and diastole. They conveniently just looked at it thinking that heart rate is heart rate. Your heart rate 76, mine may be 90, so what? Just like you just now mentioned that driving badly on a Monday morning is wrong. But that is about everything.
Mm-hmm.
Our whole lives and our life expectancy is about it. And if you look at athletes and their life expectancy, if you look at people who are Japanese, Finnish, Scandinavian and their heart rates, and you look at us, there's a whole world of difference. And then when you say, why are they dying at 90 and why am I dying at 63? No brain.
Why are fit young people who look outwardly fit as well, gym goers, why are they dying out of heart attacks?
So it will be boring if I say again that their heart rates were high.
Yeah.
But that's the reason. So the so-called really fit people, they are good, well muscled, they're doing a lot of fitness, they're eating a lot of good things, but there's a deep-seated anxiety about being perceived the right way in front of a public.
Okay.
Second thing is they're using up a lot of their sleep time in this anxiety, checking their financials, checking their bodies, making sure they got the perfect diet, perfect partner, so on and so forth. So when they looked at some of these so-called young, well-to-do people, well-placed in society, fit, taking the right kind of diet, doing all their health checkups. And most of these guys are, what we call high society individuals, high net worth individuals, HNIs, being taken care of by some of the best people in the business. So what did they miss? In fact, many people can say, so-and-so was a CEO of a company in Mumbai who was going to London for his checkup. So what could be the reason? I just told him one thing, his heart rate is high. He said, you got to be kidding, it can't be that simple. I said, that's right. The London physician saw all his electronic record, but never realized that the heart rate was high. He's under anxiety, he has not slept, he's tossing and turning to get up at 3 a.m. to do his jog along the Worli Bridge. So the heart rate is not coming down. And then he's in one business meeting, which goes into another business meeting. There's a jet flight to be caught to San Francisco. Then he has jet lag, he doesn't sleep in the flight. And then he gets up, he's rushing for another meeting. So where does it end? Human beings, just by our nature, historically, have been designed to rest at night. There's no light. But when we start replicating suns all around us, what do you expect? So I think the criticality is there's not one thing, there's not two things, there's a lot of things, but they all sum up together and give me only one clue that basal heart rate, if you're not able to control by any means, or if you're uncontrolled because of anything, either lack of sleep, too much of exercise, too much of fast food which is burning up, if you're not able to control, then you're going to die early. And if you look at some of the people who live at the foothills of the Himalayas, our own Dalai Lama, for example, 94, their heart rates are incredibly low. Because by doing all what they do, whether they're yogas or their penance, their fasting, their meditation, you can call it by any name, what they have done is activate the parasympathetic system, which I told you was the brake. And by doing that, they are in an enormous sense of calm. The heart rates must be around 55, 60. And what happens? We are all blessed with a billion heartbeats. And when I'm running at 50, 60, I've got a lot of heartbeats left. I'm 89, I'm 92, I'm 95, reaching a century. But when I'm on the go, thinking of the next project, I've just done one project, I'm on the other project. I want the other woman, I want the other car, the heart rates are going. And when they go up, you start consuming the billion heart. And then when you have a sudden stroke, sudden cardiac arrest, sudden MI, it's no brain. Why? I'm a perfectly well chiseled out guy. I do my weights. I'm on a keto diet. I have the best controlled environment. No pollution in Mumbai getting into my office. But I just die suddenly. What's a mystery? Sound.
There's a popular talk going on currently, I mean post-COVID, like vaccinations are causing these young heart attacks in these young people. How true is that, doctor?
Well, this debate has been on, and I'm certainly not a biologist, but when you look at what COVID does, COVID is not an infection. In fact, we call COVID the hand of Satan, simply because it combines two deadly things. It causes an infection on one side, it attacks the body. On the other side, it causes an inflammation. So, why do I get a heart attack when I'm a smoker? Because my endothelium, that's the inner lining, is always under pressure. It's inflamed. Why do I get a heart attack when I'm having cocaine? Because cocaine is inflammatory. It causes what you call hot plaques or a hot endothelium. Why do I not get a heart attack if I'm in a Buddhist monastery, doing penance the whole day, sitting and just reflecting in a quiet, dark room? Because by doing that, getting the parasympathetic system in order, and passivizing my endothelium, my hot endothelium gets cold. And when something is cold, what is the chance of it catching fire? Never. Have you ever seen ice catching fire? I'm sure it will happen in some strange lab which you and I don't see, but it doesn't happen. But when I already have a kerosene tin or a gas cylinder leaking in the kitchen, what's the chance of it exploding if you just light a match? Very high. So, what COVID did was it got all our endotheliums into a state of heat or a state of inflammation. And if I have the right ingredients, that is, I smoked, I took recreational drugs, I didn't sleep, I took too much of alcohol, or I'm under stress, a hot endothelium, what happens? Catches fire. So when you saw cascading vascular things happening 3 months, 6 months after COVID, I say, why blame the vaccine? Why blame the vaccine when COVID is an inflammatory disease? It attacks the very soldier that is designed to protect you. That's what made it very dangerous. COVID doesn't attack the body. It attacks the very soldier, the neutrophil and the WBC, which is trying to protect you. And over time, this hot endothelium, the infection has gone away. You gave your hydrochloroquine, you gave your remdesivir, you got treated in a swanky hospital. You got over it. The endothelium is still gone. And then you go back to why I got COVID, why I lost my mother in COVID. And you have a hot endothelium. And what happens down the line with that stress? You lost your job, COVID. You had to spend exorbitant amount to the hospital. That's stress. You ran out of medical insurance. Medical insurance company didn't cover COVID. Lost a loved one. And to compensate, you started smoking. You got into a little bit of drugs. Didn't get sleep. The hot endothelium got hotter and then exploded.
Mhm.
And when I got a heart attack 6 months later after COVID, I'm going to blame the vaccine.
Mhm.
So that's my theory.
I personally feel, Doctor, COVID instilled, I mean, huge amount of fear in people. Additionally, there was lockdown which stopped people from earning their bread and butter. Doctors such as yourself were completely overstrained, right? It made people like think like, when is the vaccine going to come? They were desperately waiting for vaccines. So I think, I mean, usually vaccines are safe if you look at things like polio and stuff. They've been proven to be extremely safe for human use. However, this due to this urgency, I think people have kind of, or the authorities or the pharma has kind of ignored or taken less time for trials and got the vaccine
In fact, if you look at the global story of the COVID vaccine,
Hmm.
we believe it's possibly the shortest time in the whole picture of history
Hmm.
that a vaccine got developed.
Hmm.
So I'm certain, and I agree with you,
Hmm.
some corners have been cut. But if you look at the large number of people who survived because of the COVID vaccine, two vaccines, or even the third one, there is a broad basic understanding,
Hmm.
which means that the vaccine was good. If you looked at vaccinated communities and non-vaccinated, and you look at the mortality rates, there's a striking difference.
Hmm.
So there would have been certain vaccines, and Pfizer was one of them, which possibly did precipitate, because when you give the vaccine, you're actually training somebody to get COVID in a controlled manner, and inadvertently, you got that endothelium together. It's possible. But if you look at the large number of deaths that happen in the non-vaccinated population and the number of deaths that you thought happened in the vaccine, the results are strong. So we always believe that anything you do in medicine, we always look at the pros and the cons. We always look at the risk and the benefit. We always look at the cost and the cost effectiveness. So in the larger body of evidence, COVID vaccine, 3 of them or 4 of them, had a very favorable net benefit versus risk. Huge benefit mortality, small risk of some events happening. Huge cost benefit to the cost that it came. So when I look at all that and I look at some of the controversies and I look at what you said about the COVID vaccine coming in a very short time, I agree. There may be some small truth to the thing, but don't take COVID out of the equation and say that what happened is only from the vaccine. The dragon in the room or the elephant in the room is COVID, not the vaccine.
Not the vaccine. Yeah. I do agree with that, but I am still curious. I came across a considerably worrisome study done by Stephen Gundry, and I think you know, of course, you know him. He found that mRNA vaccines like Pfizer and Moderna dramatically increased inflammation on the endothelium and T cell infiltration of cardiac muscle, and the findings may account for the observations of increased thrombosis, cardiomyopathy, death, and atrial fibrillation, and other events following the vaccination. Also, if we assess the 5-year risk for ACS, it was drastically increased, like from 11% to 25% in just 2 months. So, per se, if I smoked like 30 plus cigarettes, ate junk food for all 3 times of my meals, I would still not be able to, spike up my ACS risk in just 2
So there was the thing about the Pfizer vaccine mRNA, which was not there in the Indian vaccines. So although they said that the Indian vaccines were less superior in terms of efficacy, the mRNA business and the cytotoxic microRNA wasn't there. So we never really got those effects which they got. And of course, I will tell you the other part of the controversy where some Pfizer employees have been caught on tape and on phone asking them to increase the dose so that more people would get the side effect, and then you could treat that also. So all these controversies have been there for but at that time the net benefit was still there with the Pfizer vaccine because it was nothing else. We had no drug at that time to treat.
Yeah.
So if I were to get a heart attack 5 years from COVID and say that it's because of the vaccine that you gave me, I think that's a long shot.
Okay. I don't know how true is this. I was watching a podcast the other day, and when Pfizer and Moderna were in picture of vaccine making, people who got side effects were kind of sidelined out of the trial. Like they removed them out of the trial, and they continued the trial with healthy people who didn't uh, get any side effects.
Any trial that is funded by the drug manufacturer, I always tell people, take it with not a pinch but a bucket load of salt.
Okay.
Any trial which is funded by the drug manufacturer and at the end says that Moderna vaccine or Pfizer vaccine is slightly better than not, I tell my students, take it with a bucket load of salt. Because when you put $1 billion worth research, you damn well get those results, otherwise you're out of the company. Or the company is not going to be there. So be very cognizant of the commercial angle to all this. And I take these trials with a bucket load of salt. Unless it is done by a specific body like National Health Institute, NHI of United States, or the NHS of UK, or any well-placed body in the world, I take these trials with a bucket load of salt. Because the commercial angle is just so enormous that sometimes you would not even see it.
Also, I've been injected Pfizer thrice in the UK. Should I be worried?
Not now. You should have been worried a year after that. You're a healthy person. You're a healthy person with a good endothelium. But if you were, for example, a middle-aged smoker, alcoholic with bad heart disease, then maybe I would worry a little. Because an already hot endothelium is just made hot. Your endothelium was maybe ice cold. So a little bit of heating didn't happen. I'm just extrapolating. So I always look at it in the context of who's that person. I told you my whole business is KYC. I don't look at my patient with a high LDL or a high thing. I say, who is this patient? Is it an 80-year-old grandmother who has multiple issues and just about does her little work in her small little home and gets the bed ready, prepares a small meal? Is that person an ideal person to give an injection to get her LDL down to 30? Certainly no. Okay, so I do a very quick KYC of my patient. Is he a middle-aged executive flying in a jet every third day making millions of money? I say get his LDL down to 30, and if you have to clobber him, do it. Because I want that man to live to 100 and make more money. So for me, it's all about the KYC. It's not those numbers that you've been talking about, but who is that person, and for whom do you want to get that number down?
There's one more study on Israel wherein increased arrests or cardiac arrests in the age of 16 to 39 post-vaccine rollout. The study detected 25% increase in EMS calls. The findings of the study raised concerns regarding vaccine-induced undetected severe cardiovascular side effects and underscored the already established causal relationship between vaccine and myocarditis, a frequent cause of unexpected cardiac arrest in young individuals.
Certainly, as I said, the other danger that we're not talking about is that when you gave a vaccine, you had to be very sure that the person didn't have a COVID already.
Okay.
But we didn't have the tools to know that. So many of us got infected, as you know, in the those three epidemics that came along, surreptitiously by COVID. We didn't know it. When you tested my antibodies positive, I had no symptom. 70% of the population was walking around doing their business, highly COVID positive.
Yeah, true.
Asymptomatic.
Yeah.
And that's how this country and the world moved on. Now, guess what happened when you are having COVID? You didn't know about it, and you got those 3 jabs.
Yeah.
So that's a gas cylinder leaking.
Makes sense.
You were supposed to make sure that that person was COVID negative before injecting. But how many of us got tested for COVID before the vaccine? Because there was such a hurry to give it. We all just lined up. And I'm just guessing that if many of us who already had COVID or were having COVID and we got that vaccine, the EMR data that you're showing is real, highly probable. But that's speculation because I don't know that and that was not tested. But I'm just thinking that why would a vaccine just by itself, when we know the history of vaccines have been there, cause all these things suddenly? I have a feeling, and that's my little theory, that many of these people had already been infected or they had active infection. Then you give the vaccine, that's double jeopardy.
Okay. So the big pharma is not conspiring to decrease the population. Okay.
Better ways to earn their money.
Okay, let's come to statins, doctor. What is a statin? What does it do for our audience? Quickly, please.
Yeah. So we know cholesterol is bad, or rather too much of cholesterol is bad. And statin and cholesterol production happens in the liver. 70% of cholesterol happens internally. 30% is what we get from our food and diet. So in the process of making cholesterol, there are a couple of pathways. And one key rate limiting pathway is called the HMG-CoA reductase pathway. And at that point, that particular enzyme is inhibited by statin. And when you inhibit it, what happens is the production of cholesterol comes down because that's a rate limiting pathway. And depending on what statin you use, pitavastatin, rosuvastatin, atorvastatin, simvastatin, and what dose you use, that much effectively the enzyme will get blocked and the cholesterol production came down. Now, when the cholesterol production started coming down, then what happens is that the liver's ability to send receptors up to collect the LDL that have been floating also come down. So at a certain level, if you have really suppressed cholesterol, the receptors or floating dockyards on the liver to collect the ships of LDL floating around also come down.
Okay.
On the other hand, and the body has a certain enzyme, we call it PCSK9, which goes and destroys its receptor. It's part of the way of keeping the whole homeostasis there. If you have too many receptors, too much of cholesterol coming and the liver gets burned. And the body also needs cholesterol to survive. Our brain requires cholesterol. So there's a fine balance. So they have an enzyme which goes and destroys the excess LDL receptor. If you destroy the receptors, LDL are free, the levels go. So statin is in a very advantageous position where it knocks off that particular enzyme and the whole cholesterol synthesis and LDL and later on triglyceride, those things get suppressed. And if there is a drug of the century I can name, I would clearly give a standing ovation and first prize to the statin. So there's one drug which I feel has no equals, is a statin. Because as I told you, heart disease is not caused by smoking and diabetes and hypertension. We talked about the propensity. 3 to 4, LDL is 9. So if I can decrease LDL by some margin, I'm going to be in a very good position to prevent heart disease. And they found that in trials and in real world experiences, communities which had the lowest LDLs had the best survival. The risk of MACE, major adverse cardiac events, heart attacks, strokes, fatality, happened as a linear progression, right? So as my LDL went up, my events. So there was a clear example of a cause and effect, just like you saw that in smoke, where the nicotine and the tar increased and your chance of lung cancer and heart attacks. So So there are a lot of things that we don't have a cause and effect. But cholesterol and events, it seems to be a very clear linear path. The lower the cholesterol, less the events. Now, whether I did it by exercise, by diet, by statin, by the newer drugs and mRNA drugs, that's up to you.
Okay.
So, clear relation between cholesterol and heart disease. And statins is one of the drugs essentially where at an affordable dose, oral preparation daily, you get very good reduction of it. It's not perfect. Indian reduction is not the best. You have to add on, we have no drugs. But as a single drug, it's very effective.
Okay.
The other thing about statins is it has pleiotropic benefits. So cholesterol reduction is just one business. It has pleiotropic. Among the other benefits is passivation of the endothelium. Cools the endothelium down, decrease inflammation, and therefore hot plaque becomes cold.
Okay.
So you're not only taking away the gas cylinder, you're removing the guy with the matchstick as well. The gas cylinder is cholesterol. Nothing happens with high cholesterol, just like that. But when stress is added on, and inflammation is added on, it could be because of cooking, could be because of vaccine, could be because of COVID, could be because of lack of sleep, it's an explosion. So statin not only remove the raw material, which is cholesterol. If you strike a match without a cylinder, nothing happens. You get a little burn. So you have to have a cylinder for something to happen. If you have a cylinder and no matchstick, nothing. So the two together is the explosion. And statin removed the cylinder, it also removed the guy with the matchstick. Decreased it. So the twin benefit makes it what I call the drug of the century.
Okay. Since you mentioned that this can be, it's up to me whether I choose lifestyle changes or prescribed medication as statins. Why is, not in this case, not just Indian, but the global pharma, why are they not promoting lifestyle changes and prescribing statins?
So the same argument comes. I do a KYC of my patient. Who is my patient? Is it somebody like you, who's a young person, no addiction, no risk factors, family history is all clean, no blood pressure, no diabetes? Certainly you're a guy for lifestyle and no statin. You may have an LDL of 150, I'm not going to start with. I'm going to give you 3 months. I'm going to get you on a low carb diet. I'm going to get you into 150 minutes of exercise per week, little bit of resistance, little bit of cardio. I'm going to tell you to go to sleep well. I'm going to tell you to avoid the junk food. I'm going to tell you not to shout at your wife. But guess how many people do what I tell them to do?
Exactly. Yeah. 99% of them don't do it.
99% are not going to.
Yeah.
But let's put that aside. It might still work for you. But now who's my next patient? Diabetic. He's hypertensive. He has CKD. He has had a stent before. Strong family history. Same LDL as you, 130. And he never gets sleep and he shouts at his wife every day. Now, do you ever think lifestyle is going to work?
No. Not at all.
Yeah. So, my whole theme for today is KYC. Please don't judge what your neighbor did, or what your neighbor bought, or what his wife looks like, or what his house looks like. Look at yourself. That's KYC. Look at yourself in the mirror. Are you a young, athletic, non-smoker, non-alcoholic, with extremely good habits? Certainly, lifestyle, my dear, is the way to go. But are you a fat, with central obesity, hot belly, drinks 2 beers every day, fights with your wife every other day, drives like a maniac on the road? Lifestyle, not for you. You need style.
Alright.
So that's the picture.
What I also came across, doctor, was kind of worrisome, I'd say. There's not a lot of raw data when it comes to statins. How do you think about that?
See, for anything to conduct a trial today is very expensive. But if you look at the last 50 years, and if you look at the statin trials, and I showed you the benefits, when you got a patient on a good dose of statin and got his LDL down in the trial, the events were the lowest. Either you did it in Scandinavia, you did it in India, you did it in Europe. So the data is very low. Your LDL is down, payments. No two things about. And if you have to get it done by the statin, so there would be a controversy saying that statins are not God's particle and there are issues with statins. Certainly, yes. If I give it to a young guy with nothing, that's not a guy I should be giving to. It's going to get muscle pains, back pain. If I get to somebody with kidney disease who's on dialysis and I give him a high dose, he's going to get rhabdomyolysis, he's going to get a muscle protein in the urine. Certainly not the guy. So that's why I'm a physician and not an AI specialist. I need to know who's my patient, whom to give high dose, whom to give low dose. So that's the nuances of a physician. I mean, you can't be doing a test by yourself, looking at an AI and prescribing yourself. No way. Just because you know all about spacecrafts and you've run through 1,000 pages of AI module on spacecraft, you can't be Shukla going there and saying, why not me, why him?
So ChatGPT doesn't work. Okay. India now has like the poorest air quality index in the entire world. It's interesting. Nobody wears a mask. Nobody talks about, like, people make fun of me when I talk about air purifiers, air quality. What do you want to say to them? Because that's dangerously negligent for me.
Yeah, so we've looked now, there's a lot of data available with the Heart Health Foundation of India. One of the main scientists and one of the directors, I happen to know him, Dore Raj. And he's done a lot of work. And he's clearly shown that while we are scared about lung cancer, lung diseases like bronchial asthma, COPD, bad air, we are scared about when I smoke, I'm going to get lung cancer. We are missing the elephant in the room. And there's a substance called PP2.5, which actually is very small, goes into your nostrils, goes into your bronchioles, goes into the alveoli, and from the alveoli actually goes into the bloodstream and goes to the heart and does exactly what COVID did. Heat up the endocrine. And the big danger, and I call it the elephant in the room, is that PP2.5 causes more heart attacks than all these things that you've been talking about. Holy. That's the elephant in the room. We think it causes lung disease. We think it causes cancer 10 years from now. We think if you stay in Delhi that you'll get cancer at 60 instead of 80. Okay, I'm 40, I'm making a lot of money in Delhi. But PP2.5 is one of the big causes of heart attacks.
What do you want to say to people with survivorship bias? Like, we've lived. You are saying something about air quality, but we've lived our life. Our ancestors have lived for 80 years.
Yeah, certainly, yes. So, my parents, for example, have lived in cities where there was 100 cars. And I'm living in a city where there is 1,000,000 cars. So, it's all about exposure. It's like you have LDL of 130, I have LDL of 130. But I think you're around 30?
Yeah, 30.
I'm 50. But I'm exposed to LDL for double of your age. That's exposure. You may smoke 1 cigarette, you're 30, but I'm smoking 3 cigarettes and I'm 50. What is my exposure? I've lived in Delhi for just 10 years, where there's about 1 million automobiles. And my dad has been living in Delhi for 40 years, where there was hardly any vehicles. So whose risk do you think is more? So when he said, I've lived my life, certainly, and you're doing a good job, because you were around and breathing all that air when only bullock carts and horse-drawn chariots were moving around. So your exposure is less than mine for the same period of time. You understand? So we're not talking about numbers of LDL and sugars. We're talking about now exposure. So if I'm diabetic with HbA1c of 8, you have the same HbA1c, but you're 30 and I'm 50. That means I've been exposed to the toxic effects of sugar for double your time. And guess who's going to get a heart attack? Because I've crossed the level of exposure. We call it the Indian red lines. So when I say Indus River, that's a red line, don't cross it, and I cross it, they'll off. So to me, it's not about numbers. I'm going to change a little bit of the paradigm thinking and talk, what is my exposure? So have I been smoking for 30 years, 2 cigarettes, or did I smoke just for 2? So there's a difference. Have you been exposed to Delhi 40 years? Or is it just 1 year I went to Delhi and came back? So exposure is everything. So if you've had a long enough exposure to LDL, to sugar, to high blood pressure, to toxic behavior, you get a heart attack faster than the other person.
Makes sense.
That's all.
When we first met, you drew a diagram, if you remember, like explaining that we're all going to die out of heart attack. Can you quickly do that for our audience, please?
Yeah.
I'll explain.
So it again entails about exposure.
Yeah.
So this is my timeline. I'm keeping 80 because Danish live till 80, 70, 60, 50 and 40. This is my cardiovascular risk. We call it MACE, that is the major adverse cardiac effects. And this is my red line. That's an LDL. Now, if I reach this exposure faster, this line, because my LDL is 150, I don't want to correct it. I say only lifestyle. I reach it at 40. I try to decrease it and make it 130, and I reach this line at 50. I try to correct it and make it 100. I reach it at 60. I do a better job and say I want to get it down to 70. I reach it at 70. But I do an exceptional job and get it down to less than 60, and I get a heart attack at 80. So it's all about the curves and the exposure. And that's where statin use will move this shift to the right. And I'm certainly going to reach, I'm certainly going to get a heart attack, but I'm going to get it much later. Because the less and less of LDL that I have, my exposure and the time I reach that critical value, it's all about the heart rate we discussed. So I'm born with a billion heartbeats, you're born with a billion. But if I'm always on a parasympathetic, I'm doing meditation, keeping my heart rate less than 50, and you're always in a range and a rate of 90, guess who's going to complete his billion? I will also complete my billion. I'll do it at 80. You're going to finish your billion at 40. So the same concept. Exposure, exposure. So we need to understand these things very early. And only if we do that, we're going to understand why someone gets a heart attack early, why someone never got a heart attack, and what is the central sort of pivot,
If India were to implement WHO AQI guidelines, how many heart-related deaths could be prevented?
Yeah, obviously I don't have the numbers at the tip of my tongue, but certainly it will be a good number. Because as I said, that AQI is the elephant in the room. And we're clearly seeing it in Delhi today. The number of children getting lung diseases, the number of heart attacks, the number of heart hospitals in Delhi far outnumber any of the cities in India, which is a good index of what's the load of heart diseases in the country. So any drop in AQI, and now our transport minister has got some great vision of EV for all by 2030, which I think is not possible. I think now we shifted to 2040, is a creditable thing. And if we can get our air condition down by whatever technique, get the EVs in place, get the cars out of the city, have more pedestrian, certainly we're going to be living long. And our heart attack rates are going to come down because PP 2.5 is a big and clear, I call it a clear and present danger, the elephant in the room which nobody is seeing.
What do you think is the role of AI, robotics, and modern science in cardiology now?
Yeah, I think when you're looking at the large disease burden that's beginning to hit us and the lack of trained manpower, we're still a small number to tackle such a large problem. I think one of the things like the industrial revolution, the food revolution, the computing revolution, I think the AI revolution is here just in time. Just in time. Just when we thought we'll all disappear, I think in 2000, that Y2K problem, the computers, sort of came up with a solution, and now we are handling a lot of things on the net computers. So AI has come at the right time when the disease burden is almost engulfing us. and it's threatening to decimate this planet, I think AI is come just in time. That's one of the beautiful, ingenious things of the human population. They just come up with the right thing, the right time. That's also God-given, thing to a few people. So AI is going to revolutionize heart disease management because it's going to allow us to pick up a lot more people of the iceberg which we talked about, much below, much better than what the naked eye and even a good physician like me can pick up. So let us say I pick up 20% of disease in the community, AI will pick up 80%. It will make me see ECGs better, it will make me see pictures better on the CT scan, MRI. So you're going to pick up better. It's going to, a tired mind like mine at 5 o'clock wants to go home. I'm thinking more about the commute. I'm thinking about my nice glass of beer I'm going to have. So the last couple of cases just get, but AI has no such problem. It's going to be on the dot every single time, whether it's the first case or the millionth case. And operator fatigue just goes out. The only thing is, we've got to keep it safe. We've got to train the AI. And some of us are involved in this part. So AI is going to make medicine very democratic. So whether I'm a small villager in some corner of Rajasthan or I'm a super, sort of bureaucrat or corporate guy in Mumbai, I will be getting an AI-driven, personalized thing wherever I am. So it's going to make overall health better. It's going to make choices better. It's going to allow physicians to see the better choices that is available if they use AI. It's going to make physicians detect heart disease early, therefore start treatment early. AI is going to give them better choices to start with. Is lifestyle better for you? Or think AI knows better because AI is scanned you already. AI knows your behavior, AI knows your past history, which I may not have enough time to clean in a short, but AI knows it. AI has seen you in the reception, seen how you walk. AI has taken a full history. So AI knows whether lifestyle is going to work or never work. So that's going to help the physician make the difference. And lastly, AI is going to help us do procedures better. We will know for a particular patient which stent to use, which not to use, whether surgery is better, post-operative. So it's going to give our nurses, technicians who are on the work, looking after patients, much better data. So before a patient has an arrest, for example, sick patient, AI is going to warn you, at the current scheme of things, this patient is going to have an arrest half an hour. I get my defib, I call my senior physician, talk to the family, I get the cath lab ready, I prep this patient, shift him before the test. The way is going to tell, just from the projection of his numbers. As a human, not easy. Again, if I do, people are not going to believe me. They're going to believe me. So it's going to make medicine much better. It's going to make medicine more democratic. And it's going to allow us as physicians to handle the large, thing that is really hitting us, the epidemic. So I think it's a great welcome. For those of you who feel that AI is going to take away jobs, certainly it will. But it's going to take away the jobs of those guys who don't know yet. Not the physician. Physician is going to be the cornerstone, no doubt about it. You can't escape. But a physician who's AI trained, who uses AI, will be the physician on top.
Alright, doctor, that was a great podcast. It was an immensely informative podcast. We've learned a lot about heart health today, and thank you again, Jai Shri Krishna. Thank you so much for being my guest.